Hi everybody, welcome to our live stream. Today, I'm Kim Fogarty. I'm one of the physician assistants here at Jemsek Specialty Clinic. Today we're going to be talking about the rationale for Jemsek Specialty Clinic treatment strategies for Lyme Borreliosis Complex, or what we refer to as LBC. Just to give you a general overview of how today is going to flow, the beginning of our discussion today will be more of a presentation discussing how JSC views this complex illness and how we go about treating. Then, after we give you a little bit of information, we'll open it up to answering your questions. Some of them have already been posted on our social media outlets, and we have them here. Feel free to post your questions underneath the comment section. We'll do our best to answer as many as we can. But if we don't get to them, we do save them for the next live stream. Please note that this is part one of a two-part series. Unfortunately, we can't fit all of our information into one session. If you're not able to join us live, this live stream will be recorded and posted on our YouTube channel as well as Instagram. We do have some slides and some visual presentations to go along with our discussion today, and those will be available in the edited version that will be posted on those social media. Okay, Dr. Jemsek?
Thank you, Kim. I think everybody knows Kim, and some people know me, but I think Kim is, I'm her mini-me, actually. People used to say the other thing, but she is so good at what she does that I just, I say, no, I'm your mini-me. So today we're doing some things a little bit differently. This is our 15th live stream, I think, in 19 months, so we're proud of that. We'll have one next month as well with Josie Capon, who's going to be returning, and then Kim and I will continue with part two of this discussion. And you know what? There may be a part three or part four because it really gets very involved. We can't get into all the specifics of therapy. Today is about definition of terms, the complexity of the illness as we see it at the beginning. And on our website, we have a sequence of strategies which starts with stabilization, so we'll talk briefly about that. And also an overview of, why some people get sick and some people don't, and some hypotheses that I think are quite different from conventional thinking. But the fact is, folks, we've seen more patients than anybody in the world, over almost 20 years. So we have the experience, and we spend a lot of time with our patients clinically, and that's where we learn. And so our first slide, which I'm not going to show to you, just says, thanks for the opportunity. Everything I've learned, truly learned in my practice, I have learned from patients. And I'm going to take some, and that's a quote of mine many years ago. And I really believe that. And so it's important to pay attention to patients. It's important to examine patients, touch patients. And patients these days are saying, I went to the doctor, he never touched me. At least you examined me. And why do we do that? Because we find things. And we learn from that. So Kim is going to give an overview of, where we're headed today. And I'll show you some slides, but they'll all be posted later in a day or two so that you can take your time and reflect on those. By the way, if you have any comments about how they can be better or more easily explained, please offer them. We're happy to make adjustments as we set out these precepts for how to approach this complex and misunderstood and highly politicized illness. Okay,
so when you're dealing with LBC, this is a very complex infection, and it impacts the body in essentially any way possible. It affects every system. So it's a complex infection. It's a multi-systemic illness, and it's also a very complex immune system issue. And the way that we view this illness is that all of those parts are equally important. And as a general rule, as we're going through treatment, it's all about balance and organization. We have to keep your body, the body in the state of balance and organization as we move through treatment. So that's essentially our goal at each, phase of therapy, if you will. Just to touch briefly on it, from a diagnostic standpoint, unfortunately, we do not have trustworthy diagnostics available yet. It's an area of research that's ongoing. Though we don't have good diagnostic testing, there is a lot of objective data and objective evidence that helps us to diagnose this illness and actually track this illness. Like Dr. Jemsek was saying, when you come into our office for an initial evaluation, we go through an extensive visit, we go through an extensive history, we go through an extensive, what we would call a review of systems, where we go through essentially every body system, looking at symptoms and signs that you're experiencing. We do a very detailed physical exam. I have patients comment to me all the time that they've never had a physical exam like that before in their lives. And as like Dr. Jemsek likes to joke, we find things. We organize all this information and we use that for diagnostic purposes and tracking purposes. So if you come to our clinic and you're coming in for your new patient appointment, please plan on being here for at least 2.5 to 3 hours. Again, it's a very extensive exam. As a general overview, we like to think of our treatment as being 3 phases. The first is investigation and stabilization. The second is gradual intensification of treatment. And the third is healing and recovery. Again, today we're going to be talking mainly about the intensification and stabilization. And I have patients ask me all the time, Kim, which is the most important phase of treatment? Which one do you think is the most important? And honestly, I would say this is it. Because again, the better prepared your body is, the more information we have about how your body is functioning and how this infection is impacting it, the better we can help it and help it get the infection out and help your body heal. Dr. J, can you tell us a little bit about the definition of Lyme Borreliosis Complex and how we came up with that label?
Right. So thank you for your comments. And as far as tests go, we've gotten lazy and tend to rely on tests. Some of the tests are very good, but what if the tests aren't good and you tend to rely on them? Well, that leads you askew, I think. And so doctors like to marry themselves to the paperwork, which is the testing. And you know what? Sometimes the marriages don't work out. And this is a case where it's not working out. So if you rely on the test, that's inappropriate, quite honestly. You have to do the exam. Now, testing has some merit, of course, and we hope it gets better in the future, and it's work in progress. Socrates said the beginning of wisdom is the definition of terms. That'll be on your handout. We have a working case definition that I created in 2004. So that's 17 years ago. And it hasn't really changed. Major criteria being chronic, relapsing, and otherwise unexplained encephalopathy, which means inflammation of the brain, arthritic symptoms, which can be periarticular or enthesopathy, and peripheral neuropathy, generally associated with tick-borne infections, spearheaded by Borrelia burgdorferi in combination with co-infecting organisms. Now, these are major criteria. You could add some minor criteria such as erythema migrans and that sort of thing, and that would be great. There are 2 unwieldy definitions in the literature, one from ILADS and one from Dr. Stricker. They're just not workable. They're 2-3 pages long, single, it's just not workable. So we've had this diagnosis has worked for us in a great way. So most people have 2, and most people actually have all 3. And if you have 2 and you have minor criteria, that's a way to make a diagnosis. I haven't put this forward as a definition, but again, I created this in 2004, and the current definitions came out in the last couple of years. Why the term borreliosis? I will put this online, but I want to read from it because I want you to understand the concept of how I came up with this name. So complex applies to bacterial, physiologic, and immunologic manifestations of this illness. LBC is polymicrobial. So the spirochete is present, but there are several stealth pathogens, major stealth pathogens, including various strains of Borrelia, and now we're learning various strains of Babesia and multiple strains of Bartonella. And we don't know what strains are misbehaving in which person, but none of them can be adequately characterized or quantified by today's technology. It's not like you can do a viral load in HIV or viral load in hepatitis B or C. You just can't do it. You can't quantitate it. And we believe that Babesia is an essential component of the clinical expression of Lyme borreliosis. So I'll get into that a little bit later about the spirochete and its role in our body. This disease is immunosuppressive. It's not like AIDS, but it's no fun. The immune system becomes exhausted chasing these pathogens. Immunoglobulin levels and lymphocyte levels are often depressed, just like I saw in the HIV world. And the basic data haven't been reported, so that's shameful, quite honestly. We need much more sophisticated immunologic measures and testing. LBC is multisystemic. It's what I call multi-compartmental in the neurologic system, both the central and peripheral nervous system. And it's capable of killing and invading host cells because it's intracellular, the spirochete and Bartonella, for example, both functional and supportive nerve cells in the central nervous system. The pathogen profile, I call the spear. This is something we came up 15 years ago. Borreliosis is a little gold tip here. It's the tip of the spear. But you see there are other components. The spear won't fly without the support. So what we're dealing with is the sequelae of these infections, and I'll get to it in a moment, how intensely inflammatory this disease is. And remember, it's in the nervous system. It's in the fuse box. It's not in your elbow. It'd be bad enough to have a swollen, red, awfully painful elbow, but now you got a painful, swollen, and dysfunctional brain because these spirochetes, as shown by Dr. Linegood, invade all the neural cells that you can imagine. You know, the studies from 2006. This is 15 years old, folks. 15 years old. And we're no better off, really, now than we were 15, 20 years ago, which is shameful. It's an American tragedy, a world tragedy. So we have immunosuppressive tactics, immunoevasive tactics by the spirochete, written about by Singh and others, Embers, multifaceted inflammatory onslaught, multifactorial immunomodulatory collaboration, and biofilm colonies all over the place. Lipoprotein reactivity is very important. So the spirochete family, Spirochetia, is different in that its solder protein is lipoprotein rather than lipopolysaccharide, or teichoic acid in gram-positive organisms, for example. Turns out that lipoprotein, which of course syphilis shares, is in order of magnitude more inflammatory or more provocative to the immune system than the other organisms. So that's what a Herxheimer is. And here's our friend, Carl Herxheimer. I call him the dude. And he and his cousin, one was in Austria, one in Germany, both dermatologists, and they were treating patients with syphilis with the LATA, the secondary form of syphilis. So they had lesions on their extremities. And they were treating with antimony and bismuth and arsenic and things like that. And they would note that, and this was in the late 1800s, they'd note that when they treated the patients, they got febrile sweats, swollen lymph nodes, the lesions would become greatly inflamed, enlarged, exaggerate, and then in a day or two they go away. And they saw it so often they decided to put their name Jeriche Herxheimer to it, and that's what a Herxheimer is. And this was syphilis. And now we're talking about the higher order of spirochete, which is Borrelia burgdorferi. And we call syphilis Lyme's dumb cousin. So, I mean, it's capable of living only in humans, whereas the spirochete can live almost in any life form practically. And so now we have the Herxheimer reaction, and so that's the source of inflammation. So we have this going on in the poor brain. The brain's being destroyed. The cells that are infected die. Fortunately, we have 100 billion of them. There is some evidence that regeneration can take place. That's a work in progress. But you have to stop the inflammatory onslaught and let the brain recircuit and recover. And so we're going to talk about the timing of that. So, okay, so I've come up with concepts. Again, we see more people than anybody in the world. So we have some license to make concepts counter to mainstream, because mainstream hasn't seen these patients. We believe, learning about the biology of the organism, that Borrelia is capable of infecting just about everyone. And once it's in, it's in. It's akin to the herpes virus group. So once they're in, they're in. So HSV1, 2, CMV, EBV, zoster virus, HPV-6, 7, and 8. Once they're in, they're in. And that doesn't mean you're going to get Lyme disease, but they're in. And that's never been really studied. The incidence of in utero transmission is woefully inadequate. It only takes a spirochete or two to get in, and they're in. And there's nothing to contradict this. There's been no prevalence studies ever. In the stealth pathogen paradigm, I'll repeat, I think Babesia is paramount to the expression of the disease, but there's more to that, and we'll get to that in a moment. The chronic inflammation associated with LBC is unparalleled. It's maniacal. There's nothing like it, unless you're in end-stage AIDS or end-stage cancer. It's nothing like it. This disease wasn't on the earth in this form, in this prevalence 30 years ago. So we have a highly inflammatory disease that requires some immune reaction, but the immune system is faltering. It's making noise, but it's not controlling the situation. So it's kind of like COVID. You're all familiar with the inflammatory storm that COVID caused. That's because it gets behind the immune system. And the immune system, instead of being inert, tries to play catch up and causes all this inflammation and without controlling it and causes all this damage. And that's how people get really sick, and that's how they die, primarily due to promotion of clotting. And we also think that in our population, and if we had research people here and funding and grants, we could do tremendous work because, our chart survey, seeing several hundred patients a year, we could start to chart the incidence of coexisting chronic illnesses of unknown etiology, such as any of the rheumatologic diseases, any of the degenerative neurologic diseases, many of the GI diseases, which have no known cause, right? Now, I'm not saying the borreliosis causes all this, but it's in a genetically susceptible person, you're going to see different expression of illness. Some people have major polyarticular arthropathy. Some people have predominant dementia or seizures or mood, some neuropsychiatric issues. Some people have major GI issues, and so forth and so on. So it's important to understand this illness because, we literally spend hundreds of billions of dollars managing these chronic inflammatory illnesses in other systems, which go by names like Crohn's, MS, even psoriasis, and so forth. The list just goes on. And I've lectured on this many times. So I'm going to stop for a moment, but a quote I made in 11 was that LBC has no peer nor precedent in human illness because of its unique ability to routinely and efficiently disassemble the human nervous system, and in doing so, may create a major disconnect from life and reality. And that's the sad part. It does so much damage to the brain in some people. They dissociate, they can't communicate, they can't process, much less multitask, and their family may or may not be supportive, and they just feel lost. They've lost their self-esteem, and they have no way to get it back. And I'll stop right there to let Kim comment on that, because what do you think about all the things I just said?
Well, I agree with Dr. Jemsek in that there is a desperate need for more information and more research about this complex illness. And I know Dr. Jemsek will be the first to tell you, I'll be the second to tell you, by no means do we know everything there is about this complex infection. I've been working at JSC for over a decade, and it's amazing to look back and see how things have changed, even in the time that I've been here. Dr. Jemsek has been doing this longer than me, but it's an evolutionary process, and by no means do we know everything about this. And every day, I think we hear or see new things that we need to investigate, and we need to understand how to address them and how to correct them. Again, this infection can essentially invade any tissue in the human body. And it creates a lot of instability and volatility, as Dr. Jemsek was saying. It creates a lot of inflammation. Inflammation is bad for our bodies. The more inflamed a tissue is, the more dysfunctional it's going to be. And two of the hallmarks of this illness that I have trained my brain to think of is when you have multiple body systems that start going awry. You have the nervous system, the gut, the musculoskeletal system, the skin, the endocrine system, the immune system. Everything starts going crazy. Also, because of the inflammatory nature of this infection and also the immune chaos that ensues, every day for a Lyme patient, unfortunately, is very different. And Dr. Jemsek likes to use the analogy of the needle. Where is the needle falling in terms of homeostasis? And we do have a slide that you guys will be able to see. How we explain it is, if your inflammation is low, you're going to have a better day because tissues are going to, and systems are going to be able to work better. If your inflammation is high, you're going to be more out of homeostasis. You're going to be more out of balance, so your body's going to be struggling. To expand on what Dr. Jemsek was saying about the Herxheimer reactions, or what we refer to as herxing, as a general rule of thumb, any issue that's being compounded by this infection has the potential to flare when the infections are dying, and that's what we refer to as herxing. It's different than what Dr. Jemsek was saying than syphilis. That's just a fever and muscle aches and things like that. With Lyme, it's a lot more extensive. It can be, pain. It can be mood issues. It can be gut issues. It can be skin, changes. There's a lot of different manifestations that present with herxing. Now, keep in mind, because of this infection can impact any body's system, it's actually amazing from a scientific standpoint to see how diverse our patient population is. This infection can impact everybody very, very differently. If you speak to other patients with LBC, you'll find that there will be similarities, but there's also a lot of differences. When we go about approaching this illness and this infection, it has to be customized to the individual. Like I said, from stabilization through treatment. Again, there may be similarities if you compare protocols and you compare treatment strategies, but there is a very systematic approach, and there is a strategy that we go for. There are certain markers and things that we need to see and that we need to appreciate before we can shift gears and before we move on. As Dr. Jemsek said, he's coined the term restoring ELF, which is essentially essential life functions. And because this infection is so disruptive, it robs people of their essential life functions. And that's our objective, is to restore that through a very systematic process. The other adage that he's coined is that it's important for us to keep in mind as you move through treatment, POEMs. Dr. Jemsek, could you talk about POEMs a little bit?
Sure. Thank you for that. Right. So once you're inflamed and the landscape is damaged, it takes less toxin to, upregulate or either downregulate that neural function. And so when you're having a bad time, maybe you had spaghetti and didn't sleep very well, or you're stressed out about your family or your job, and you're going to have a worse day. And it's really not fair. It's really cruel, quite honestly, that our patients that are so damaged, they have such a narrow window before they get inflamed. But when you're having a good day, that means the toxins are down, you took your supplements, you had a salt bath or a sauna, you did a little stretching and toning, maybe you got a massage, a proper massage or acupuncture. And by the way, we use the best of the East and West. We're not an antibiotic farm here, okay? I just want to make that clear, because everybody thinks, you come here, you're just going to get plugged in IVs. No, some people do that. We don't. I never have. We've learned over the years about Eastern medicine, and there's some good things there, and there's some things that I don't believe in, but we try to use the best of the East and West, because Western medicine just doesn't cut it. It just doesn't. So we have this little thing. Actually, when you see it posted, the needle will move, and this is our barometer. This is our oximeter, if you will. So we all have oxidative stress every time we breathe, we eat, we sneeze, we cough, we move. But it's quickly neutralized. These reactive oxygen species and other mediators that are toxins are quickly neutralized by our liver, glutathione, representing 70 or 80% of the antioxidants. Guess what? When you have a chronic inflammatory storm 24/7 with Lyme Borreliosis, unlike anything on the planet. Unless you're dying with AIDS or dying with cancer, then you die. And with Lyme borreliosis, you will die, but not right away. And you're going to be so dysfunctional, you may die. And suicide is the number one reason, but there are other reasons. But it's a slow, painful journey and a slow, painful death, and you've been robbed of your ability to communicate and enjoy activities that you used to and so forth and so on. But you're chronically inflamed. So the bottom line is inflammation. Another bottom line is your immune system that needs to be restored. Is that possible? Well, yes, it is possible. It's a slow process. So we have some diagrams. We need to go ahead and sort of speed things up, but I'll go ahead to the poems that Kim spoke about, and the ELF, Essential Life Functions. So we have this is animated too, so it's kind of fun to look at. But poems is something I came up with, I don't know, 15 years ago. Pain, other, which means support primarily, also means there's about 25 roadblocks that will show in our next session. So we've come up with a unique set of conditions that we either preclude therapy or sabotage therapy. And one of those is, including the poems group. So it's pain that's uncontrolled and unrequited, other conditions such as gallbladder disease or toxic relationship, and there's 25 other issues there. The endocrine system is very important. We'd like to know especially what the cortisol is, because that's life-threatening if it's low, and it's not uncommonly low due to secondary hypocortisolism, meaning that the pituitary has been hit and it's not producing ACTH. So the pituitary and hypothalamus get hit big time in the upper part of the limbic system, in the center of our brain. M is for mood. So I've had this lecture before with Jules Capon, and we talk about our mood condo. But just to remind you, everybody on the first floor is irritable, okay? And it just gets worse. Everybody is irritable with this disease, frustrated, irritable. And if you're off the reservation, here's another metaphor, or you're not on the playing field, or you're out of the bandwidth, that's like 3 bad metaphors in a row. We need to get you back in. You don't have to be perfect, you just need to have some stability there. And so we'll either manage that with the tools available to us, or we'll work with a psychiatrist. And we have to have a family member involved. So when you come for this long visit, even though there's an expense, I understand, of somebody traveling from, thousands of miles, it's really good to have somebody with you, if that's possible. If not for the first visit, then for the second. And the last letter in poems is sleep. So sleep is essential life function. We've learned a good bit about sleep. And the thing about treating this illness is you have to be proficient in numerous disciplines. You don't have to be the expert. And when there are experts working with us, we're happy to collaborate. We're happy to learn from them, and sometimes they learn from us. It's not all about us and doing it our way. If you have a psychiatrist or a sleep doctor or a really good physiatrist, we're happy to work with them. Physical therapists are typically very good. They just really do great work. Do you think it's time to talk about our protocol approach?
Sure. So again, we with stabilization, just to sum up, what you can expect leaving your initial visit. Most of the time, our patients do not leave with antibiotic prescriptions because one, we either need to investigate further and get more information on into how your body is being impacted. Typically, we do laboratory studies looking at nutritional deficiencies, what Dr. Jemsek was talking about, the endocrine system, thyroid, cortisol, reproductive hormones can also be impacted. We have different strategies that we do to help stabilize pain. Most of our patients have what we refer to as complex pain. The pain is coming from multiple sources in the body. Sleep is imperative, so we have different strategies to help with sleep. Sometimes our patients will need a sleep study to see what exactly is going on. We try to get the GI tract as ship shape as possible, and we have different strategies to do that. We try to lower the inflammatory quotient in the body. Dr. Jemsek was speaking about saunas, Epsom salt soaks, exercise, stretching and toning, and things like that. What we want to do is we want to essentially level the playing field and get some protective barriers in place so that your body can function better and that your body will be able to handle the antibiotic therapy. And again, the more balanced we get your body at the very beginning, the better your body will respond. And like I said before, we don't go about this in a very haphazard way. There is a strategy. There is a system in place that we look for, even though it's very different for everybody. Unfortunately, many times by the time our patients get to our office, they've seen multiple providers, dozens of providers. That's not unusual. And though progress with this illness is very, very slow going, for everybody, you can get better. It does take a team of support, like Dr. Jemsek was saying, whether it be family members, friends, medical professionals. Our patients do get better, and you can get better. Dr. J?
Thank you, Kim. Yeah, in terms of support, we love it when there are doctors that are interested. Look, the way this illness has been hijacked and mutilated, and I've been talking about this for a lot of years, it's hard for physicians on the outside to comprehend what we're doing or comprehend the illness because there's no good literature out there. It's not in Cliff's Notes. But if that doctor is tolerant and knows that the patient is ill, knows it intuitively because they've got a good soul and they're well trained, we're more than happy to communicate with that doctor and go through the learning process with them. And it's really cool to have this person from Ohio or Pennsylvania observe that our patients are getting slowly better because they've been a problem in their practice for years, but they haven't dismissed them. Now, there's some doctors that say, "Oh, that's just hooey," and but this has been going on for 20 years. I mean, it's not going away. And so when we stabilize, it's kind of like, you want some more metaphors? That's a rhetorical question. So it's sort of like starting the plane on the tarmac or in the ditch. Where you want to start? Where you want to get that plane up in the air from? You want to start on the tarmac or the ditch? Or it's like taking your race car and having it sideways on the side of a mountain versus being on the Autobahn. Where do you want to be? So that's the whole point. We need to stabilize you so that your inflammatory quotient is reduced, that your stressors are reduced in a reasonable way. That doesn't mean they're eradicated because that's often impossible, but better. Good enough so that you can go through therapy, which you start slowly, and we make adjustments as we go through treatment. We'll talk about that next year. We make adjustments. And so if a patient is all of a sudden having insomnia because we put them on an early program, then we have to make adjustments so they have to sleep. And that's just one example. Once we reduce the central nervous system excitability, which is very common, the limbic excitability, where patients are having all kinds of mood issues, sleep issues, confounding memory issues, and so forth. Once we stabilize that, and again, this is done in the context of doing lots of laboratory testing to check the outliers. So that's a very important part of what we do. So the POEMs, we have to check those boxes in order to treat anybody. We won't treat anybody that doesn't check those boxes because we want to succeed for the patient. We want the patient to succeed, and this is what it takes in this very complex illness. Treatment we're going to talk about next time, but we like to think we use an intelligent approach and mindful approach, and it's only through hard work. I've said this before. I think what we do should be its own discipline. There should be, in one day, hundreds of physicians certified to treat tick-borne illness. Not necessarily just like Jemsek, but in a coherent scientific way, backed by science. Because after all, this is a disease affecting millions of people, including children, people of all ages. And it's a national tragedy that it hasn't been embraced. And now COVID is putting a big blanket over everything, and I'm not minimizing or trivializing the COVID, but it sucked the oxygen out of the room. And so we just limp along. As you know, it interfered with our GLA-sponsored study, which was collaborating with various universities, which would have been awesome. So I'll stop there, and I'll just show you quickly a couple of graphs that you can dissect and criticize. And everything I'm showing you, I've lectured on various times. So evolution of chronic illness, I'll just put that out here. You'll have time to review this and maybe critique it and make it better. But this was just my thinking about, okay, if everybody has Lyme Borreliosis in their body, and we know they need Babesia, but not, what makes them sick? Well, I see three main categories as genetics, environment, and lifestyle. We'll take the easy one first, lifestyle. Obviously, if you abuse your body, you're going to immunosuppress your body, and so you get major life stressors beyond the pale. That's going to affect your immune system. The environment is the big unknown. There's 1,000 new chemicals coming into our environment every year. I can't imagine that's good for us. We talk about volatile organic compounds in our living environment. We talk about things leaching from canned goods. There's just all sorts of things that make you crazy. I'm not smart enough to get into all that and figure that out, but it's a pretty scary proposition. Then we talk about these frequencies from high towers and all that sort of thing, which I'm not expert on. And then genetics is important. We all have substitutions in our genetic pathways for methylation. Methylation is how we detox. And if you have a lot of mutations, you have trouble detoxing, and that makes your disease worse. You just can't get rid of the toxins. Just like when you sleep, you don't sleep well, you don't get the deep sleep, you can't get rid of the toxins in the brain. That's how the brain detoxes. So you'll see this here, but it all sort of filters down to life, the pathogen profile to poems, I'm sorry, I'm not very good at this. I'm not a Vanna White.
Come on, Vanna.
So, where's Vanna when you need her? But the nice thing is you'll have a chance to look at this thing. Now, one word that's missing is that when you express the illness is that the patient's immunocompromised by this point. So the immune system has lost control of this band of infections. And the spirochete is really slippery. It really is. With all the life forms and the way it can move around, being a spirochete, can drill here, drill there, can morph when it gets stressed. This is another more general form, but the same idea. So it's genesis of LBC and associated diseases. And it really goes through the same thing. And again, the one thing that's missing, so we talk about all the evolution of the deterioration. So when your poems start to fail, so failure your poems, so let's say you have problems with pain, you have problems with other illnesses or roadblocks that we'll talk about, problem with mood, problem with endocrine issues, and problem with sleep. All of these is just kind of like taking the support from a scaffold one by one, essentially, and then ultimately it collapses. How many metaphors is that today? That's a lot. Okay. So, and I have another one. These are all original, by the way, but they're not, I never say they're perfect, but if you like them, you like them. So this one is our last one, and it talks about, in a bubble form, in this graph, how to get better. So if you don't mind, I'll turn around and read it. So it starts with antibiotic, neurotropic, psychotropic, anti-inflammatory, herbal therapies, all working together in harmony, which is followed by addressing metabolic derangements and then reduction of oxidative stress and inflammatory radicals, which lowers the fire. Remember, we're in the nervous system, we're not in the elbow. Mitochondrial support. So there's mitochondrial deficiency. You can't make ADP when you're chronically oxidized. The electric potential in the cell is diminished. You can't fire the electron chain transport system. But with treatment, you get restoration of cellular membrane integrity. You get growth. Some of the brain cells start to reconnect. You get neurorehabilitation as your brain starts to learn. So when people get to a certain point, we talk about brain exercises and brain health. And that's a big topic these days. And then finally, we have restoration of the essential life functions. So I hope you enjoy that slide. And then my last slide is another quote, my favorite quote. And it's not by me. You know I like to quote. I like quotes anyway. I like Churchill. I like Osler. This one, though, is so good because it typifies people that are out there that have power And they're the greatest enemy of knowledge because they're not ignorant, but they have the illusion of knowledge. So they are delusional in terms of, I know this, when you don't. It's just so easy to say something like, I don't understand that, I need to learn about that. And there's no basis for any sort of power figure in medicine or politics to say, I know everything. It's much better to be humble. You can learn so much being humble. It's incredible. And so we are, I know you don't think I'm a very humble person, but I really am in terms of the respect for the patient and what we learn from the patient. What good is medicine without a patient? You can be in the ivory tower and have published a book or two, and guess what? When the patients go away, you stop writing, unless you're writing your memoirs. Because medicine is nothing. To answer my own question, medicine is nothing without patients. Nothing. There is no medicine. So why do we abuse our patients?
Okay. So that was our review on the first phase of treatment with JSC, which is stabilization. I think we're going to use the next, the latter portion of our live stream to answer some of your questions. Again, feel free to comment on ways that we can improve our live streams and improve our delivery of information to you, because we do enjoy that, and we want to make sure that everything is as crystal clear to everybody as we can. So to start off with a question that was sent in earlier, how do you know it's Lyme Borreliosis Complex versus something else autoimmune? Dr. Jemsek?
So we go through our definition, we go through our extensive testing. We have our own criteria that work out. Laboratory testing can be helpful to support that. There are some common deficiencies in key molecules, coenzymes, key vitamins, mitochondrial support molecules. Key findings, usually if you find multiple things, multiple systems and certain physical findings, you can be pretty sure. Testing sometimes comes with the patient, which is good to have, because it's not the patient's fault that everybody relies on the testing. And, I'm okay with the testing. I'll just say, there are fact laws in Maryland and Virginia, which, are supposed to be issued by doctors who order Lyme tests, saying that a negative test doesn't rule out Lyme disease. Now, having said that, autoimmune disease or autoimmune processes inevitably develop in some patients to some degree. But there's a driver, and that's the pathogens and the immune response. However, the pathogens do so much damage to our tissues. It's sort of like putting a tiller in the field and uprooting, soil that hasn't seen the light of day. And so our immune system, already confused, may see that as foreign and create issues. So the most common, so I don't say there's never an autoimmune component. That doesn't mean we treat with steroids or antimetabolites, but Hashimoto's is very common, and there's anti-TPO antibodies and anti-thyroglobulin antibodies, and it's like a big so what. You treat it the same way. It's not, associated with malignancy and so forth. But that's one disease that's autoimmune, and there are others, but this is primarily a pathogen-driven illness. The body wasn't engineered and evolving over the past many centuries to attack itself. And finally, we do see some mixed conditions, and not knowing the cause of scleroderma or rheumatoid. But sometimes we work with rheumatologists who use highly selective antimetabolites, not steroids, and we're okay with that. Sometimes you have to go with that. And so there are compromises in terms of immunosuppressive medications, as long as you're working with a very good rheumatologist in this case.
Just to piggyback on what Dr. Jemsek said, there's a lot more autoimmune conditions today than there was, 15, 20 years ago. And we have a lot more questions than we have answers as it pertains to autoimmune disease. What is causing our immune systems to be dysfunctional? Is it genetics? Is it environment? Is it infection? Not all of our patients have an autoimmune component, but we do see an overlapping component. And in most of our patients, it's being driven by the infections. Oftentimes, if we can get the infections down and we can get the immune system reorganized and more in control, we will see that the autoimmune condition will go into remission. If there's an outside source, whether it be an environmental toxin or a genetic issue and things like that, obviously what I've found personally, clinically, is oftentimes the autoimmune condition will lessen or stop progressing. And again, we will coordinate treatment with a rheumatologist as we continue to investigate ways to help improve and reverse that immune dysfunction. We have a question here. Why do a cyst buster at the end of the cycle rather than at the beginning? The cystic form is a defense mechanism of the spirochete. If the Lyme feels like it's being attacked, it will revert into a cystic form. The containment or the components that is inside the cystic form is not viable outside of that cystic form. So what we do is we strategically place cyst busters in our protocols. We drive the spirochete into the cystic form, and then we hit the cystic form to, again, attack one of its defense mechanisms. So there is a strategy as to why things are placed in certain order and in certain sequences.
Yeah, if I could just comment on that. So the immune system can't tell the difference between a devolved, non-functional spirochete that's released from a cyst form from a live one. So you still get a big Herx reaction, especially. So we use imidazoles, as most people know. There are a couple of options, but so that's Tindamax and Flagyl, and that's big Herx time for some people. And so we have about 3% of people that really like Flagyl for some reason. They're just things we don't understand, but they say I want more Flagyl because I feel really good on it. But most people don't love Flagyl.
We have a question here. Is the off week the most important time to detox during a cycle? As we were discussing earlier, this infection and this illness is a chronic inflamed state. Your body is constantly churning up inflammation. It's constantly dealing with toxins. So if you think about it, again, our body is constantly eliminating waste and irritants through our breathing, through our sweating, through our urine, through our feces. And that's one of the reasons why we do those things. As a general rule of thumb, the good news is you can't over-detox your body. The bad news is there isn't one way that's going to take care of all of it. Oftentimes, if you wait until you feel like you need to detox, or you feel like, I'm feeling toxic and I need to detox, you're already behind the 8 ball because things have been building and things have been building up. So as a general rule of thumb, I tell patients, be consistent with your detoxing. It'll help, stop those peaks and spikes of inflammation. So I tell people, get yourself into a rhythm where you're detoxing all the time. Dr. Jemsek, could you discuss, we have questions about Bartonella's role in this infection.
I think Bartonella is ubiquitous as well. It's a silent organism that I believe most of us acquire. And this is an opportunity for me to express another concept about this polymicrobial illness. And I was the first one to assert that it is polymicrobial. I did it through trial and error 15, 16 years ago. And I used to think, well, I'll test this one, I'll test this one. I don't need to treat this one because the test. Of course, that was a disaster. And then after a while, I just said, you know what? In time, everybody sort of rolls into, having complex infections. Now, the spirochete itself is formidable, but I really do think it takes a team to suppress the immune system. And I look at it as, because I did so much AIDS work for 2 decades, I look at this as another immunosuppressive illness. So here we have things colonizing the body, but they're in the first tier of, possible reactants like herpes zoster. So people get immunocompromised, first thing they get is shingles, then maybe they'll get thrush later. So they're kind of in the first tier. They're not deep down like CMV and EBV and that sort of thing. And they're in the first tier. So, and they also create immune damage, immune stress. And so when they get ahead of the curve, you can either wobble for a while and you try to compensate. That's why people work out more or sleep more or go gluten-free. There's all kinds of things in our society that indicate we're not well because people want to feel better. And I'm not saying that's a bad thing, but look at all the commercials, info commercials with, compounds from seaweed to cactus and a better form of fish oil. And then everybody's getting a sleep device where the bed goes up, the bed goes down, the head goes up, and the pillows and all that. And so everyone wants to feel better and optimize their life. And I'm not saying that any of these things are bad. I just think it reflects something we didn't do 20 years ago. So I look at it as an opportunistic infection. Bartonella is one of those. Now I've always said that there are probably multiple pathogens, but the ones we can identify and treat, and in our view, we're treating them, vigorously, people get better. So, I think if we treat the first tier of, just under the water level, so to speak, then we can restore immunologic stability. And it's all about getting the immune system back in charge. Bartonella is a sneaky thing. It follows the spirochete wherever it goes. It is a intracellular organism. It's gram-negative. Almost impossible to culture unless you have specialized labs like North Carolina State, and is capable of causing, several clinical pictures. Now, folks will ask me, okay, is that the spirochete or is that Babesia doing this thing or is it Bartonella? Actually, we can say more about Bartonella than some of the others because there are some specific conditions. One is if you have low-grade fever, on and off. That doesn't happen with our population, as inflamed as they are. They don't get fever, but that does happen with Bartonella. And so I think in that case they have disseminated Bartonella. I found splinter hemorrhages, which is what you see in endocarditis, where bacteria and antibiotic complexes filter down to the very small blood vessels, in this case under the fingernail or toenail. Osler's nose or something I haven't seen, that's another sign of endocarditis. Remember, I'm an infectious disease trained person here. Bartonella also causes exostosis, which is bony growth. It's kind of like a crop of, delta, new land on the delta that comes up. So you can have a little bone growth on your joints or your finger or somewhere on your gum, and it's new. And that's called exostosis. So the osteoblasts get activated, the ones that make new bone, and the osteoclasts are not keeping them up, and so you get new bone. Another thing it's famous for that we think is cyst. Cyst everywhere. In the brain, in the breast, in the lungs, in the liver, in the kidney, in the ovaries. So if patients just loaded with cyst, we say it's Bartonella. Eosinophilic esophagitis, which is infiltrative inflammatory esophagitis, usually at the lower esophagus. If it's biopsy that shows eosinophils, that's Bartonella. I've treated somebody years ago just with Scepter, which is specific for Bartonella, not a great Lyme drug, and they got better. And so that's a sign of Bartonella. And I think, just to mention, it's vasculopathic. So it's attracted to the endothelial cells, but so are the other pathogens, but this one especially. So our endothelial cells are only one cell thick lining our entire arterial and venous system, and it loves endothelial cells. So it burrows in and creates all sorts of vasculopathy, which can translate to all sorts of funky rashes. Sometimes rashes, which we know as stria or stretch marks. And those are also a classic sign of Bartonella, although spirochete can probably do the same thing.
We also have gotten several questions regarding the role of parasites in this infection. And we would like to refer to parasites as stealth pathogens. They take advantage of the immune system being dysfunctional and not being able to keep order. Now, everybody has parasites. It has nothing to do with hygiene. We come in contact with them through our food, our water, and our environment. And again, if a parasite is impacting the body, it actually acts as a big distractor to the immune system. We do incorporate antiparasitics into our treatment protocol in somewhat of a gentle fashion and a systematic fashion while we're treating the complex, because again, it's about trying to get the immune system back in control so that these things that are part of our natural biome and that reside in us in general aren't causing additional problems. So when we go through our treatment, we do address parasites, and there's all kinds of different parasites, just like there's all kinds of different, bacteria. And believe it or not, responsive treatment and clinical findings can help direct us in that regard as well. Dr. J, we have a question here about long-term damage in patients with LBC.
So yeah, so if you think about it, our first job is to purge the infections in an orderly way, in an intelligent way, so that the tissues damaged can have a chance to repair, because inflamed tissue, infected tissue can't repair. So at the end of the therapy, our patients often have been so severely impacted that they still require, obviously, to stay on a low inflammatory lifestyle, but they require various supplements, various neurotropics and psychotropics to get the neurotransmitters up to snuff, because the receptors may be destroyed. There's fewer receptors, for example. And so oftentimes depression is worse at the end of therapy, whereas compared to the beginning, but other things are a lot better. The physical exam is better, they're functioning better, but the mood's not there yet, so they need support until the brain has a chance to heal. And I think everybody can intuitively understand that the brain takes a while to heal. We need to learn about that. We're not sure that all parts of the brain can heal equally well. The hippocampus seems to be able to heal. That's our memory center. The paraventricular areas seem to heal well. That's some of our processing. So things definitely heal. Exam gets better. But it's been a scorched landscape, and so once I explain that to patients, if they're having problems, our job is to say, oh no, you don't need more therapy. Here's what's going on, and sure enough, they've had another stressor. So patients are very labile with stress going, with this disease going through treatment and for quite some time afterwards. So healing time takes 2 to 3 years, and that's living the low inflammatory lifestyle. And again, the patients are disadvantaged because their threshold for firing off or shutting off is lower than an unaffected person. And
we're unfortunately running out of time, so we're going to do one more question before we sign off. Dr. Jemsek, at what point is it okay to stop all antibiotic therapy, and where we feel secure that they're, in remission?
So for years, I don't know, 3 or 4 years I started doing this, I just felt like I knew there was immune recovery. You can't really measure it as recovery because the thymus is gone in most of our patients, and so new cells aren't coming out. But you're regenerating other parts of the immune system. And so the timing is, we have a plan when we see you, and most patients know that. We have a plan. The treatment is generally in the order of 12 months, dosing 8 to 9 times a month with rest periods and downtime, and doing sequencing. So it's not just all the same medication, but we're always treating the spirochete. And we're concentrating on Babesia for a while. We're actually retreating Babesia after people finish their first round of therapy, first year of therapy, whether it's IV or oral. If they've been really sick, I think it's smart, once they go to maintenance, which is 3 days a month, 3 days a week in 1 month, you stay on maintenance. I don't want you herxing on that. You shouldn't be herxing, and you're recovering. You are actually stimulating the immune set. But because Babesia is the number one reason for people to stall out and chill and relapse, which in a lot of patients we're starting to retreat, and no one else is doing that. But it's our recognition of how nasty this organism is, and the fact that the second treatment we have our immune system helping a little bit more, and then I think that ensures longevity of remission and reduces the incidence of relapse.
Okay, well, I want to thank everybody for joining us today. And if you're watching this later, please feel free to comment and send in additional questions. Unfortunately, we weren't able to get to everybody's questions, but we will save them for our next live stream. Again, this is part 1 of a part 2 series regarding our treatment strategies. So stay tuned, and we'll see you next time. Thanks.
Thank you, Kim. You're wonderful. I think we're going to have 3 parts. Are you up for that? You up for that?
Sure.
Yeah. All right. God bless. Bye-bye.